Okay, I think we're all set now. Hi, everyone. Good morning. So thank you for all for tuning in and for all the work that you're doing on service. Today, I'm going to present the first of a two-part talk on ARDS and management of refractory hypoxemia. So today, we'll focus on the pathophysiology of ARDS and defining ARDS, and then tomorrow, Sasha Wong will explore more the nuances of management. So here's our overview for today. As I mentioned, we'll explore the pathophysiology of ARDS and review the diagnostic criteria and identify mild, moderate, and severe ARDS. And then we'll go over an initial approach and how to troubleshoot mechanical ventilation in ARDS. So to begin, patients who develop severe COVID-19 infection requiring ICU admission for hypoxemic respiratory failure do so because they have developed ARDS. Before the pandemic, ARDS accounted for about 10% of ICU admissions and 23% of all mechanically ventilated patients worldwide. And this comes from an epidemiologic study called LungSafe. Of course, now during the pandemic, those prevalence numbers are much higher, and non-COVID or non-ARDS.
Can I leave and rejoin?
What's that? Okay. So non-COVID or non-ARDS ICU admissions are a much lower percentage for various reasons. But although epidemiologic data are still in the process of emerging, we do have the largest case series of critically ill patients, COVID positive patients from Italy, was about 1,500 patients. And this gives us some insight into the characteristics of this population. So in this group, about 88% required mechanical ventilation, and they had about a 26% ICU mortality rate. And interestingly, the median age of about 63, the median P to F ratio, or 160, and the median FiO2 of 65% in the first 24 hours were all similar to the averages found in LungSafe. So this gives us some hope that most of what we're seeing is what we know, ARDS. We're just seeing more of it. So what is ARDS? I think when asked this question, it's really tempting to reach first to the diagnostic criteria, but we'll spend the next several slides focusing on the pathophysiology of ARDS, which has really been elucidated over the past 50 years of basic science research. So ARDS is a diffuse inflammatory lung injury that disrupts the alveolar vascular interface. So the injury leads to an impairment of the alveolar and vascular epithelium that leads to profound capillary leak. This floods the alveolus with non-cardiogenic pulmonary edema, inactivates surfactant, so promoting alveolar collapse, and leads to an imbalance of coagulants and anticoagulants, resulting in the formation of microvascular thrombi. Many of you have seen this image. This is from an excellent review of ARDS in the New England Journal by our own Taylor Thompson. And here we'll take a deep dive into what I've just said, just illustrated to illustrate this process. So on the left, you have a healthy alveolus with the bronchial epithelium transitioning into this single layer pneumocyte. The alveolus is filled with surfactant, which reduces surface tension and helps keep the alveolus open. And then you have an alveolar macrophage, or one of the most prevalent immune cells of the lung. So in the first phase of ARDS, the exudative phase, which occurs over the initial days to week of ARDS, there is an injury, which is either direct to the lung tissue, as in the case of pneumonia or an aspiration of gastric contents, a pulmonary contusion, or something like an inhalational injury, or indirect to the rest of the body that then creates systemic inflammation, as is the case with sepsis or pancreatitis or TRALI after a transfusion. And that leads to an inflammatory cascade. There's activation of the immune cells and this cascade of inflammation that is a response to that injury, with the consequence of disrupting the alveolar epithelium here and the vascular epithelium. So there's the loss of integrity, that results in flooding of the alveolus with this protein-rich fluid. And then at the bottom here, you can also see depicted there has been vascular wall injury and tissue factor dependent coagulation, which results in those microvascular thrombi. So how would this process manifest in our patients? What would we see? Well, flooding of the alveolus with fluid would lead to wet and stiff lungs. And inactivation of surfactant would result in those alveoli being prone to collapse. And then lastly, with the microvascular thrombi, that overall creates a higher pulmonary vascular resistance and worsens dead space. So if we take a moment to review these two graphs, which were presented as part of Dr. Hibbert's lecture actually on Friday. The first on the left is a pressure volume curve of the lungs. So you have volume over on the left and pressure on the right. And I just wanted to point out that the slope is compliance. So the change in volume over the change in pressure. And as the lung stiffens, you need more pressure, a greater change in pressure to result in a change of volume, which lowers the compliance. So ARDS is a disease of low compliance. Over here on the right, if you look at, imagine this is our rendering of a ventilator tracing. So on the ventilator, this is a pressure versus time curve. And so as we move from left to right on the x-axis, there is the evolution of time. So I have the pressure labeled here. So this is your PEEP. And as a breath is delivered from the ventilator, you reach a peak inspiratory pressure. And if we do an inspiratory pause here, the pressure that is due to the resistance or flow goes to zero because there's no flow, and you're left with the plateau pressure. So that plateau pressure minus the PEEP is the change in pressure that we refer to that is actually distending the lung. And we can use that difference in pressure to get an estimate of the compliance. So I wanted to display this here because, again, ARDS is a low compliance state because the pressure required to distend the lung is high for a given volume. Any questions on that before I move on? Okay. So ARDS is also a disease of phases. So the first phase that I presented to you was the exudative phase. And this is a proliferative phase, which we hope happens on the order of week to weeks after the onset of ARDS, which is a reparative process. So in this phase, type 2 pneumocytes, these are pictured over here, they are serve as stem cells, which regenerate themselves and also the type 1 pneumocytes. And that repopulation of type 1 pneumocytes restores the barrier function of the alveolar epithelium. And there's also an influx of fibroblasts down here, which reestablish the interstitium and help that reestablished interstitium helps resorb some of the alveolar fluid, which then drains via the lymphatics. That fibroblastic proliferation can go awry and lead to the fibrotic phase, which happens on the order of weeks. And this is a smaller subset of patients, but they can go on to have extensive proliferation of the fibroblasts that leads to laying down of excess collagen that stiffens both the intraalveolar and interstitial matrix. So the pathophysiology that I've just outlined informs the diagnostic criteria that we use to identify ARDS via the Berlin definition. So this is released in 2012, and we'll just go through the components of what you should be looking for in these patients. So the timing of ARDS is within a week of a known clinical insult. The presentation requires chest imaging with bilateral opacities that have the appearance of pulmonary edema, but is not fully explained by pulmonary effusions, specific collapse, nodules, or masses. And the origin of that edema, again, cannot be fully explained by heart failure or cardiogenic causes, essentially. We categorize patients in their severity according to the P to F ratio. So dividing the PaO2 by the FiO2 as a decimal will give you the P to F ratio, which is a marker of severity. And I wanted to highlight here that these are all chest radiographs that would be considered typical for ARDS. They don't all look quite the same. You can see in some, particularly the one all the way on the left, the disease is a bit patchy. Over here in this one in the center, there are some regions of which look like spared areas of the lung. And over here on the right, this patient essentially has disease involving all the lobes of the lung. However, the characteristics that they have are that they all have bilateral opacities that have the appearance of pulmonary edema without having cardiogenic pulmonary edema. So why do we care so much about the P to F ratio? That is because these categories were determined because they were able to predict the mortality of those patients who had the specific P to F ratio. So these cutoffs were chosen because folks presenting with that category of P to F ratio had a mortality of the ranges that you see here. So to highlight, folks with severe ARDS where the P to F ratio was less than or equal to 100 had a 45% mortality. And the other reason that we pay attention to this is that clinical trials of strategies to manage ARDS or the inclusion criteria are often moderate to severe. And so that will help us guide treatment decisions. So now we'll review an initial approach to mechanical ventilation in ARDS. So the goal is to use the ventilator to improve oxygen while minimizing ventilator-induced lung injury. We essentially use the ventilator to provide supportive care so that we can either treat the underlying problem or allow the lung's own reparative processes to occur. And really the cornerstone of ARDS management is lung protective ventilation. The reason for this is that low tidal volume or lung protective ventilation saves lives. So this is from a paper in 2000 of about 800 patients with ARDS from the ARDS trial network. And you can see here that survival at 180 days was significantly different between these two groups. One having lower tidal volumes, which were about anywhere from 4 to 8 cc's per kilo, versus traditional tidal volumes, which were at the time much higher, ranging from 12 to 15 cc's per kilo. So there was a significant survival benefit. And now we'll dig a little deeper into what is actually meant by that, by low tidal volume ventilation. So using the volume control mode of ventilation, I just outlined sort of what you set on the ventilator and then what you monitor. So low tidal volume ventilation is defined as tidal volume set at 4 to 6 cc's per kilogram of ideal body weight. And just a reminder that ideal body weight depends on both gender and height of the patient, and not actually their actual body weight. After you set the volume, you can choose an initial respiratory rate for a goal minute ventilation. So just keeping in mind that patients' normal minute ventilation is maybe between 5 and 8 liters, and there are some states in which they have a higher minute ventilation requirement. For example, if patients are already presenting with significant hypercarbia. And then you can set an FiO2 and PEEP to maintain oxygenation for these goals. So your goal PaO2 should be between 55 and 80. Or if you don't have arterial blood gas, you can also go by the oxygen saturation, so that PaO2 would convert to about an oxygen saturation of 80 to 95. And then let's take a look at what you monitor. So
actually, a quick question from the group is asking if the PDAF ratio in COVID ARDS has been shown to be related to mortality.
Oh, so that's a good question. I think that thus far we have pretty preliminary epidemiologic data. So if we go back to the cohort or the case series that I presented on the first slide, which was of the 1,500 patients out of Italy, their PDAF ratio, the median PDAF ratio was about 160, which is similar to LungSafe, but their ICU mortality was only about 26%. So there is hope that the mortality that we're seeing, although there's hope that the mortality rates that we're seeing are lower than those reported, than the severity, than the cohort that they used to validate the breakdown for mild, moderate to severe ARDS in that Berlin definition. I think that the other piece that I'll add here is that for those of you who have received the FLAIR emails last night, Laura Brenner published one that reviewed the latest case series from New York. And from what I've read from that, Laura, and you can also correct me if I'm wrong, but their mortality rates, although these were not necessarily limited to the ICU population, their mortality rates were lower.
Yeah, they had lower mortality rates, but they are missing, about I think 27% of patients have not finished, their course, so we don't know what happens to them. So they're a little bit difficult to interpret. But the other case series are also, the PDAF ratios range from 140s to 160s in the different groups from Seattle as well as Italy.
Okay. So all right, switching gears here a bit. So I've reviewed the initial approach to what we're setting on the ventilator. The other key piece here is what to monitor. So if you are using a volume controlled mode and your pressure then is going to be dependent on the volumes that you set. So here we're going to monitor pressures, including that plateau pressure, with a goal of keeping that under 30. And you can also pay attention to the driving pressure, which is the difference, again, between the plateau pressure and the PEEP. And there's some retrospective data that patients with a driving pressure of less than 15 have improved outcomes, or that there is a higher mortality associated with having a driving pressure of over 15. And we also want to monitor pH and PCO2. So troubleshooting low tidal volume ventilation. There are two issues that we commonly encounter with using low tidal volume ventilation. And the first is hypercarbia. So because we're limiting tidal volumes, and both tidal volume and respiratory rate are the components on the ventilator that allow us to ventilate the patient, we allow permissive hypercarbia just to facilitate having those low tidal volumes. But if the patient develops acidosis, you can take two strategies. First is to increase the respiratory rate, And then if the pH is still less than 7.2, liberalize the tidal volumes. So the other issue is sedation. So remember that these patients are spontaneously breathing, and spontaneously breathing patients generally take tidal volumes of about 7 to 8 cc's per kilo. So we're shooting lower than that. But patients who are in respiratory distress may be taking much higher volumes. And so it can require significant sedation to have the patient become synchronous with the ventilator, breathing those low tidal volumes. And so we'll have an entire lecture from one of our amazing ICU pharmacists, Christy Phillips, on strategies for sedation, particularly in patients with COVID-19. But in particular, the use of opiates will help to decrease the respiratory drive and provide some analgesia. And then lastly, there are adjunctive treatments in addition to low tidal volume ventilation, which you're going to use to manage the refractory hypoxemia of ARDS. And each of these listed here, we're going to have specific talks on in this lecture series. And Dr. Sasha Wong will be reviewing these in more detail tomorrow. But to start, conservative fluid management after the initial resuscitation, optimizing PEEP, either via the low PEEP ARDSNet table or by best tidal compliance. Prone positioning, which has been shown to have a mortality benefit in moderate to severe ARDS. Paralysis if needed to achieve synchrony, and pulmonary vasodilators, in particular for hypoxemia, although that hasn't been shown to have a mortality benefit in ARDS. And then lastly, ECMO. The patient has failed all of the measures above here. So I think I'll pause here and open it up for questions and discussion, particularly given the timing.
The question comes up, when we do best PEEP, are we saying the ventilator PEEP the same or +2?
The question was, when we do a best PEEP trial, should we be using that or adding to? Is that right?
Yes.
Okay. Well, I can see the chat as well. Here we go. So there you can use two strategies essentially. So when you're doing the best PEEP trial, you are essentially trying to find the PEEP at which you have achieved the best compliance. And you have the option either to use that PEEP or to add to. And the basis for that is something that Dr. Hibbert mentioned on Friday in the last session, which was that there is heterogeneity of, so it's not some lung units are going to be underdistended at that PEEP and some are going to be overdistended. And so adding to is a way to sort of make sure that you are sort of prioritizing being able to open underdistended units. So either strategy is appropriate.
And then the next question is, COVID-19 leading to more or less phase 2 fibrotic ARDS than usual?
That's a great question. So I think that it is still too early to say. In many of these case series that have been released, including the one from Italy, and especially the one from New York, many of the patients in particular from the case series from Italy were still requiring mechanical ventilation. So it's a bit too soon to say if they will go on to be extubated and have restoration of their normal lung function, or if there will be similar rates of progression to the fibrotic phase and sort of this chronic critical illness, respiratory failure. What is clear is that the rates of folks who are going to need sort of LTAC or post-hospitalization care are going to be high, and that's definitely an issue that we'll have to address from a health system standpoint.
Any other questions from the group? We have a few more minutes. The next question is, does best PEEP in the supine position necessarily correspond with the best PEEP when proned?
Oh, that's a great question. So patients who are in the prone position may require less PEEP than patients who are in the supine position. And the reason for this is that PEEP is one of the parameters in the ventilator that allows us to keep alveoli open. And there's a greater tendency for alveolar collapse in the supine position. So you may have heard that some folks are taking the strategy of establishing the best PEEP in the prone position, if that's a technique that you're using in your patient, and then prior to flipping them back supine, adding about 2 centimeters of water of PEEP with a goal of sort of preventing collapse when the patient resumes the supine position. So the hope is that it is close, but it is probably lower in the prone position.
And then the next question is there an understanding why a number of COVID patients have a normal or high compliance compared to patients we typically see with ARDS?
That's a great question. Yeah, so with the, I think anecdotally, many of us have realized that we're seeing many patients who have a compliance of, say, 40, with sort of normal being, 50 to 100. So it's striking that many patients are having a compliance that's not terrible, but are severely hypoxemic. And I feel like the answer to many of these questions is that it's still unclear. And that is unfortunately the answer to this question, that it's still unclear why patients have sort of that normal or higher than we would expect compliance that seems out of proportion to their degree of hypoxemia.
Yeah, I think also there's, just so much heterogeneity in ARDS and, and a lot of the cohorts don't report their compliance. So it's hard to know that, we probably see a range of compliance in our patients.
Mm-hmm. Yeah, definitely agree.
These are all really great questions. I think that, in the interest of time, we'll probably start to wrap up unless anyone has a burning last question for Megan. All right, it looks like you may have answered all of their questions, but thank you so much for giving us this great overview of ARDS. Any last words for us?
No, thank you, everyone. Take care. The lecture will be posted on the website, and we'll email out a link.